with the centers in both in Bareilly and as well as Sir Khatima. Dr. Agrawal has delivered sir multiple talks on glaucoma diagnosis and its management. And today,
दयानंद
sir,
तुम्हारा फोटो साफ नहीं आ रहा है थोड़ा ऊपर right.
I hope, sir, right now I am traveling, sir, so might be थोड़ा सा sir network issue हो.
नहीं नेटवर्क ठीक है तुम फोकस करो ठीक से अपने
Okay.
टिल्ट कर लो हाँ यस
Yes, it's. So, sir, just sir, welcome to Dr. Agrawal, and today he will be speaking on the topic, sir, cupping of the optic disc. So we are honored to have him with us. Dr. Agrawal, now the floor is yours, sir. You can go ahead.
Thank you. I'll jump right in. And so my topic for today is nuances of optic disc coupling, a differential diagnosis approach. So why I've chosen this topic is because when we see a patient with cupping, right away we think glaucoma. However, my topic for today will focus mostly on non-glaucomatous condition causing optic disc cupping. So the anatomy of the optic disc region is simple. It can be divided into the central, the laminar region, and the prelaminar and the retrolaminar region. So the laminar region is the area of maximum interest here because it contains it has a sieve-like connective tissue structure which through which the retinal ganglion cell axons pass through. So of course there we know that RGC, the laminar globulosa has pores. But there is a regional difference in the size of the pores. This is the most critical point because of the difference in these size of the pores, there is a regional difference in the damage of the RGC cells, ganglion cells. So if you see, this is the nasal part of the laminar tuberosa pores. You see these are smaller pores. However, inferiorly, you see the pores are much bigger. And the connective tissue septae are thinner. And here the connective tissue septae are much thicker. Next slide. So this is the inferior part. Sorry, this is the temporal part. And here you can see the pore size and compare this to the superior part. You see the pore size. So that because of these larger pores, superiorly and inferiorly, and the decrease or the less amount of connective tissue support here, these pores, these connective tissue septae, they get distorted very easily, and there is damage of the retinal ganglion cell axons which are passing through these pores. So this is another full laminar tuberosa you can see. So superiorly, you can see the superior pores, and the inferior pores are much larger than the nasal and the temporal pores. So these pores, superior and inferiorly, they get very easily damaged because of the constant high intraocular pressure in glaucoma. So you get notching superiorly and inferiorly. And nasal and temporal parts of the optic disc are relatively spared till the very end in glaucoma. This is very important to remember. So this is the part through which the papillomacular bundle axons, which are the macular fibers from the macula, they are passing through the optic disc. They are primarily known as the papillomacular bundle. So they subserve the central vision, which is the most important part of a visual acuity. So again, you can see these are the inferior pores, and these pores are the nasal ones. So what is cupping? Cupping is the pale central depression in the optic disc, and there's a ratio which is usually established between the cup size and the disc size, and this is known as CDR, or the cup disc ratio, and this is very important to note in cases of glaucoma or any condition of cupping of the optic nerve. So the important point, as I've highlighted here, is that the asymmetry between the cupping in the two eyes. This is where immediately your mind should jump. If you notice any sort of asymmetry in the cupping size between the two eyes, you should immediately be alerted and try to investigate it further. Asymmetry more than 0.2 between the two, between the CDR between the two eyes. So this is schematic diagram of the cupping of the disc. See, initially, you can see this is the shape when the cupping has not started. When there is no progress in the cupping. This is you can say this is the virgin cup, which is not being affected by the intraocular pressure or other causes of the optic disc cupping. This is how it progresses. This is how it ends. So from a triangular type of a cupping, and you can see this is a cylindrical type of a shape. And this is the new, this is the internal limiting membrane. This is the new position of the internal limiting membrane. See how far it gets pushed. You see how the shape changes. And this is the Brooks membrane opening. This is the Brooks membrane opening. And so you can see that this is how the cupping progresses. So now coming to the next very important part, that's the blood supply of the optic nerve. It is, as we all know, is supplied by the short posterior ciliary arteries. We form a circle of Jin and Haller in the area of the prelaminar and the laminar area of the optic nerve, and they supply this part of the optic nerve. And of course, CRA also supplies the central retinal artery, also supplies a very superficial part of the optic nerve, but that's very insignificant. So this is a classic diagram which we all have seen, and this is courtesy Dr. Sohan Singh Hare, who is a stalwart and the father of the ischemic optic neuropathies. So here is there is the short posterior ciliary arteries forming this circle here to supply the optic nerve. So here you can see this ophthalmic artery giving rise to the posterior ciliary artery and the short posterior ciliary arteries, long ones, and they forming the circle of Zinn and Haller around the optic nerve. This diagram is very interesting. I hope everyone knows this is an ICG view, and you can see this triangular pattern of the uh, choroidal vessels. So in between, this is the watershed zone. Watershed zone. So watershed zone is a territory between two separate, two adjoining territories of vascular supply. So if suppose because of this watershed zone, these areas become very vulnerable to any vascular damage, insult. So now coming to the optic disc watershed zone, so they are usually for the superior temporal zone, the inferior temporal zone, the superior nasal one, and the inferior nasal one. So this becomes very important in the context of non-arthritic anti-ischemic optic neuropathy, because here the entire optic nerve is not involved. Only a part of the optic nerve is involved. Only one. So usually it is a superior temporal watershed zone which is involved. And once this is ischemic and it is damaged, it will cause a inferior nasal scotoma, which is the commonest form of scotoma seen in patients of non-arthritic anti-ischemic neuropathy. So here, through the anatomy, through the blood supply, we understand how and what type of visual field defect we'll see in a patient of non-arthritic anti-ischemic optic neuropathy. So again, a beautiful work from Dr. Hire. Here you can see the watershed zones. See, these are cases of of ischemic neuropathy, ischemic involvement of the eye. You see, there's a loss of blood supply here, while the adjoining areas all have blood supply. This is the choroidal one. This is not a retinal blood supply, this is a choroidal blood supply. So why glaucoma? So again, from the watershed zone concept, we understand why glaucoma and anterior ischemic optic neuropathy is a sectoral. However, CRAO is a devastating condition because of these watershed zones in the optic nerve head and in the choroid, they are spared. They are not. They are spared in cases of ischemia because they have the blood supply is segmental. If there is obstruction of the SPCA, the short posterior ciliary artery, the entire optic nerve head is not going to get blasted away, or the choroid is the entire choroid is not blasted. You get triangular defects or geographic defects in choroid, and similarly you get sectoral and latitudinal defects in case of optic nerve. However, in retina, if there is a CRA obstruction, we all know we get a pale retina in the cherry dot spot. So this is an evolutionary damage limitation design of the choroid in the optic nerve. This is very important to understand, which helps in sparing the optic nerve head in choroid in case of ischemic events. So yes, the optic disc is in a perfect ischemic storm because of the watershed zones which are present, and there's an absent blood-brain barrier, and in cases where there's a nocturnal hyperperfusion, sorry, and there is already compromise of the posterior ciliary arteries because of hypertension, dyslipidemia, cardiac conditions, and so on. So these vessels, in cases when there is an nocturnal hypertension or hypoperfusion because of sleep apnea, or taking of antihypertensive medication at night, they can cause a certain ischemia or vasospasm of these vessels, and they can lead to a sectoral ischemia of the optic nerve, which is known as a non-arthritic ischemic optic neuropathy. And the patient is going to notice this when the patient wakes up in the morning. The first thing he wakes up in the morning, he says, कि मुझे धुंधला दिख रहा है. So this is the most typical history that a patient with NAION will give. This is very important to remember. Basically, arthritic, there is nothing like when the patient get up in the morning, he'll notice poor vision. Arthritic, it will strike any time. There is a complete occlusion of the entire circle of gel inhaler because it's a total ischemia because of vasculitis. So there will be complete vision loss. However, in non-arthritic one, there is incomplete vision loss. Patient will report of some blurring of vision, and he sometimes the patient notes scotoma also that inferiorly मुझे चलने में दिक्कत आ रही है, मुझे नीचे देखने में दिक्कत आ रही है. So this is a very common complaint. So if the patient complains this, remember you are dealing with a patient of uh, ischemic optic neuropathy, especially non-arthritic one. So again, I'm trying to bring this all together so that once you understand the anatomy, once you understand the blood supply of the optic nerve, it will be very easy for you to understand why cupping happens and why cupping happens in different type of conditions. So the nerve fiber bundles and the laminar connective tissues, they sit side by side. And if there is any condition which is causing ischemia, like a vasospasm, so these REC will swell up. And these laminar capsules pores, they will act like compartments. So they will prevent the swelling from spreading. So that will cause it, because of the compartment syndrome, the swelling will increase manifold, and that because that ischemia will increase. So another important point, why RGC cells are unmyelinated until the laminic reversal, so that the retina will have optical transparencies, so that they are thin, the unmyelinated fibers are thin, so that the retinal thinness is preserved, so that it preserves the optical clarity of the retina. And finally, these unmyelinated fibers, they are flexible, so they will absorb all the eye movements, the saccades and the sudden eye movements, and the shearing stress sometimes happens because the sudden eye movements. These unmyelinated fibers, they're going to absorb them. However, however, they are very vulnerable to mechanical strain, ischemia. So this becomes the Achilles heel in cases of glaucoma. So that is why damage happens in glaucoma because of the strain from the intraocular pressure, which causes the constant ischemia. So these fibers, they are not able to sustain it. If they had been myelinated at the lamina crebosa, there would have been probably no glaucoma. But since they are unmyelinated, they are susceptible to pressure, they are susceptible to ischemia, so that we got all type of optic neuropathies. So again, another slide telling us how this is a busy slide, so I'll just skip it. But this shows that connective tissue the astrocyte dysfunction starts, and finally there's retinal ganglions and axon apoptosis, which happens within 12 to 24 hours of the ischemia, constant ischemia, which is not relieved. In fact, which is sustained by the compartment syndrome caused by the laminar cabrosa pores, and finally these die out, and we get the optic disc atrophy and cupping. So this posterior ciliary artery circulation insufficiency, very important slide. You see that I have compared three conditions: high pressure glaucoma, low pressure glaucoma, and anterior ischemic optic neuropathy caused by vasculitis. This is arthritic AION. Here you see the pressure is high. Other two conditions, the pressure is normal. All three conditions we're going to get cupping, significant cupping. But the PCA perfusion here is reduced. Here it is much more reduced, and here it is totally absent. And here it is caused by there are many factors. One of them is a vasospasm, and there's a and here it is caused by a complete VC occlusion. So there are different causes of optic disc cupping. Can be glaucoma, can be pits, coloboma, retinal conditions, and cranial vascular conditions, and toxic condition also. So what is the prevalence of non-glaucomatous optic disc cupping? 95% it is glaucoma. When you see cupping, 95% is glaucoma. But yes, 5 to 10% it is not glaucoma. So we end up treating these 5 to 10% cases also as glaucoma. This is the gist of the talk today, that how to recognize that this 5 to 10% is not glaucoma. Correct. So non-glaucomatous condition, as I've highlighted, can be because of so many other causes. The cupping can be because of so many other causes other than glaucoma. So this is just 5 to 7%, like I said, but this 5 to 7%, like we see in workplace accidents, surgical complications, medical errors, the reactions, all of them are about just 4 to 5% or 6%. But this percentage is the most important thing. This is what we are scared of. This is what we are scared of. This is what we try to prevent. This is what we are scared of, and we try to prevent our best. So this seemingly small percentage represents a rare but clear diagnostic dilemma. As medical professionals, we are trained to be vigilant and prevent these rare but significant errors. This is our professional responsibility. Remember this. Recognizing this 5 to 7% of non-glaucomatous condition is our professional responsibility. So these are some congenital causes of disc cupping. Like I told you, that cupping can happen in many conditions. So this is a morning glory disc. This is a coloboma of the disc. This is a tilted disc. This is optic nerve hypoplasia, and this is a megalocephaly. So here, all these conditions you get a cupping. But if you see such a patient, don't really jump onto a glaucoma and start treating the anti-glaucoma medication. Again, a very busy slide uh, telling us all these things, all these different causes. See, we come across patients of ethylbutyl toxicity, methanol toxicity, tobacco alcohol associated toxicity. We do come across patients of nutritional Ozempic, now era of Ozempic use. We come across a lot of patients of nutritional optic neuropathy. Leber's hereditary optic neuropathy, it is not rare, it is pretty common. You just have to keep your eyes open for it. And these often autosomal dominant optic atrophy from sleep. So just in a very short, if you see a young man with a rapid sequential blindness, which happens after a certain episode, I've seen a patient who went for exam. It was a stressful condition, developed sequential blindness in both eyes. Was treated with methylprednisolone and later developed cupping, and was treated then with anti-glaucoma medication. So be careful. So this is dominant optic atrophy. When you think it is dominant optic atrophy, there is cupping. You see a young child with cupping, but if there is a gradual progressive visual loss, intraocular pressure is within the normal range, and there is a significant temporal pallor. See, glaucoma does not have significant pallor of the neoretinal, but in most conditions other than glaucoma, you will have significant pallor of the neuroretinal limb. And Wolfram, you get a child with diabetes, deafness, and cupping. So very interesting slide. Here we can see this is a glaucometer disc, this is a non-glaucometer disc. Both are cupped. So we'll be treating this as glaucoma. Hell no. Let's stop. Let's you consider whether this is glaucoma or not. This is glaucoma. Here you can see the notching. There is nasalization of the vessels. There is parapapillary atrophy. All these signs. There is neuroretinal ring which is still pink. Despite the significant cupping, the NNR is still pink. Here the NNR is pale. There is no nasalization of vessels. There is no bennetting sign or notching. Nothing. But still it is pale and it is a cupped disc. So this is an autosomal dominant optic atrophy. And the visual field defect, you see, this is the visual field defect in this congenital condition. And however, in glaucoma, you see this typical horizontal raphe respecting inferior arcotoscotoma defect. You just have to look at everything. You see the visual field defect, you see the optic disc very carefully. This is the glaucometer disc, this is the non-glaucometer disc. Don't treat this as glaucoma. Another set of conditions, this is the methanol poisoning. I believe all of you must have seen these cases. This is the initial condition the patient presents you. There's this swelling, RNFL edema. This is how he ends up. And if you see the patient like this, maybe bilateral, mostly bilateral, will you think this is glaucoma? Yes, you can think this is glaucoma, but see the intraocular pressure, see the pallor of the neuroretinal vein, see there is no nasalization of the vessels, see there is no notching here. So please stop, look at the intraocular pressure, think again, make your diagnosis carefully. So when we see cupping, we have to think whether it is a glaucomatous optic neuropathy, or is it a normal tension glaucoma, or is one of the ischemic optic neuropathies, or is it because the compression happening on the optic nerve? All of these things can cause optic disc cupping. So again, a useful slide here. Uh, Glaucoma, gradual, symmetric, slowly progressive, preserved color vision and vision till the very advanced stage. You get a 90% cupping patient is 6'6". Non-glaucoma, it is abrupt. एक महीने पहले दिख रहा था, अब नहीं दिख रहा है. The patient can come to you with cupping. It is usually asymmetric. One eye will be cupped, other eye will be not cupped, or there will be a cross difference in the cupping in the two. There will be pallor of the new retinal vein, and there will be color vision loss. There will be an RFPD also. So yes, key differences in the cupping or features of the optic nerve in conditions of optic nerve glaucomatous and non-glaucomatous optic neuropathies. Normal disc consistently follows the isn't rule. Glaucomatous, it just throws the isn't rule out of the window. You got a vertical elongation of the cup, and this is very important. And you got vein eating nasal displacement of vessels. In ischemic optic neuropathies, you get cup in here. In arthritic, you get cupping in up to 80 to 90% of patients. And here you can get into 5 to 10%. It's not common. It usually you see rarely in non-arthritic cases. You see cupping, still see cupping in up to 50 to 20% of patients. Here it is a very diffuse chalky where the entire disc is white and very pale and almost gets completely covered, mimicking glaucoma. Here it is sectoral atrophy and there's a pallor of NNR. So yeah, and another slide, which is very interesting. So non-arthritic, it is an ischemia from the short posterior ciliary arteries. There is gliosis of the axonal loss, gliosis, laminar going posterior going of the laminar curvature. And here you can see it is giant cell arteritis induced. There's a profound ischemia because the complete occlusion of the vessels. And primary open glaucoma. Yes, what is happening here? There's a chronic intraocular induced mechanical strain, which causes extracellular matrix remodeling in the laminar curvature, the astrocyte activation, and finally the RGC apoptosis. So this is a progressive IOP dependent condition which is happening in primary open glaucoma. And like I showed you, because of the structure of the laminar curvature, it is the cupping is usually happening at the top and at the bottom. The nasal and temporal parts get spared. The laminar deformation is happening, which is because of the chronic IOP induced mechanical strain. So yes, in glaucoma, you usually have preserved color vision, but if you test it, then you can get blue-yellow defects. Non-glaucomatous optic cupping, you will have color vision loss very early on, red-green color defects, because the papillomacular bundles are affected. That's why you get the red-green color defects in non-glaucomatous. Most of the non-glaucomatous optic neuropathies, you will have loss of the, some loss of the, at least some loss of the color vision. So why the papillomacular bundle is affected? Because there's a very high metabolic demand. They need a constant blood supply. They need constantly all the nutrition. So if there is a metabolic condition, if there is a toxic condition, if there is a nutritional defect, so these papillomacular bundles they get affected very early, leading to temporal pallor, maybe cupping in some cases, and early loss of vision, early loss of color vision, early loss of visual fields. So, yeah, visual field patterns, you know, or you all know that glaucoma can cause the superior and inferior aortic scotomas, which respect the horizontal rapid, and you can get these nasal steps. Interesting in arthritic, in this non-arthritic anti-ischemic optic neuropathies, like I told you, because of the effect of only a sector of the short posterior ciliary artery, we get these altitudinal defects. Usually it is the superior temporal zone which is involved, so we get an inferior nasal scotoma. Patient will have difficulty in seeing while walking, while reading. In arthritic, the entire nerve is gone, the whole vision is gone. Usually, the patient will not be able to perform visual fields. In compressive, hereditary, toxic, you usually have a supercentral scotoma. They're usually bilateral. Remember, they're bilateral. Color vision is affected somewhat. They will bilateral supercentral defects or any type of defects you can you can get all these conditions. In compressive optic neuropathies, which are involving the chasm, you will get a bitemporal hemianopes. And the OCT findings, glaucoma, in all these conditions, we'll have some defects of the RNFL and GCC-IPL. Of course, we have done OCT in all these type of patients where we will see glaucomatous cupping, a parallel of the optic nerve. We have done OCT in all these patients. We've done visual field in all these patients to know about all this. So just going to highlight a couple of things. Yes, this is my favorite slide. Of course, this has been taken from this paper. So whenever you see this thing in the GCC IPL map, On the OCT, remember always and always do the macular tube on your size machine, or you do the 3D wide scan on your, I don't know what it's on your Topper machine. I don't know what is exactly called, but you need to map this GCC IPL in all your patient. Wherever you see any problem with the optic nerve, you need to see these ganglions early. We see this. This is a clear-cut line which is happening, defective line of horizontal defect line which is happening in a condition of glaucoma. This is a glaucomatous patient. So this is the defect. This is preserved. This inferior part is so you see the notching here. The inferior part is gone. You get this red face sign here. Where if you see this design in any patient with a on a GCC mapping, no, it is glaucoma. No, none other condition caused this. As far as I know, this is glaucoma. This is what? This is compressive lesion. This is a compressive lesion. This part is lost. This is preserved. A vertical loss of the GCC IPL. Here you see the temporal pallor happening here. This is what? Vertically the GCC IPL is lost here, and you get this defect here. And this is optic neuritis. The entire disc is pale. The whole GCC IPL is gone. The entire thing is red. There is the generalized depression of the visual field. Visual is very poor. So this is arthritic. This is non-arthritic. Again, why I'm stressing, because these are the arthritic is not very common, at least in India. I haven't come across many patients, but this is the commonest optic neuropathy after glaucoma. You are definitely going to see it. You have seen it. You might have missed it. Remember, any patient 50 to 75 got dyslipidemia, diabetes, and cardiac condition, high blood pressure, and sudden loss of vision on getting up in the morning, you are dealing with an AION. So there's a sectoral edema of the disc. The ESR is normal. See, focal choroidal in arthritic, this is an alarming condition. This is a medical emergency. This is an ocular emergency, ophthalmic emergency. You see, the other chance of other getting involved is up to 50 to 70%. See, recognize, understand this is what you are dealing with, and immediately start the patient on steroids, IV methylprednisolone immediately. This is an emergency. You should not miss this. You should not be seeing a patient with both eyes discupping and complete loss of vision. This is what you have to realize what you're dealing with. If you see a patient with cupping, very pale disc, don't miss it. Investigate, do as an ESR, CRP. You will pick this up. Ask for temporal headache, jaw claudication. Should not miss this. See a disc cupping. Remember to keep all these things in mind, especially when it is asymmetric. There's a lot of pallor of the new retinal. Again and again, I am stressing on the same thing. So yeah, so in primary open-angle glaucoma, there's a mechanical stress. Usually you get 50 to 80 years old. Cupping exceeds pallor, very important. In normal tension glaucoma, again, the cupping is more than pallor, but you get a more pale MNR compared to POG, because here the vascular factors are important. Multifactorial, transcameral pressure gradient. CSF pressure has also got very important role to play here, and this can be vascular disability. There can be genetic causes also. So these patients on normal tension glaucoma, they share genes with LHON. They can be defective genes also. So they have basically they have a hereditary condition where they are actually they can get develop a cupping of the disc. Their disc is already at risk, so they develop cupping very fast when they develop any condition of hypoperfusion or dyslipidemia, diabetes, or any of these vascular conditions. They will compromise the function of the disc very rapidly in a patient with normal tension glaucoma. However, in non-arthritic one, this is, as I told you, it's a watershed ischemia, patients 50 to 75. This is monophasic. This is not going to happen. This is not progressive. Remember, this is progressive. This is progressive. These two are not progressive. Again, glaucomas are progressive. Non-glaucomas are not progressive. Remember, most of them are not progressive. Even if you see them in a progressing stage, in a very short period of time, like maybe a 2 3 months time, the disc will go into atrophy, pallor, and you see cupping. If at all you see cupping, because cupping is going to happen in 5 to 10, 15% patients of these conditions like ischemias, compressive lesions, toxic metabolic conditions. These conditions are monophasic. They stabilize within 3 to 6 months. Pallor exceeds cupping, pallor stays cupping. So here you see very important to notice the asymmetry. If there is asymmetry, look always and always and always look at the other eye. Don't just stop at cupping. The other eye is fine. You can be dealing with coloboma. You can be dealing with non-artery. See the other eye. If it's almost no cupping, then you're this at the disc at risk. You are dealing most likely the cupping has been caused. You have not seen it. The patient has come to you much later. You see cupping, the other eye is disc at risk. You are dealing with this. Compressor may appear pale but not chalky white. Here it is chalky white elderly patients. So now you have a patient whose pressures are normal and he's got cupping. There's an asymmetric cup and you've done your visual fields. They're not very helpful. They can be a sequocentral scotoma. Now, what do you want to do? You have to decide whether you want to neurologize this patient. If it is caused by some compressive lesion in the brain, you should not miss it. So you have to decide whether it is an atypical cause of a normal tension glaucoma. We have already labeled as a glaucoma, but it's a normal tension glaucoma. It's not a high pressure glaucoma. So we are dealing with a condition where we have already labeled the cupping as glaucoma because this is what we are used to doing. 95%, 97% of the patient we see they are glaucoma. So we already labeled the patient as glaucoma. But now we have to decide whether this is typical or this is atypical. Look at all these things. Symmetry, whether it is symmetric, asymmetric. A typical normal tension glaucoma with low normal pressures in both eyes, you will see cupping. Pressures are normal. You will have classic arcuate visual field effects. You're talking about real glaucoma with low pressures. Elderly patients, they will have some vascular conditions. Okay, dyslipidemia, they can have hypertension, they can have other conditions, cardiac conditions. So if you go for MRI in all patients of low pressure, cupping, the MRI yield is very poor, even 0 to 1%. You are not satisfied, your patient is not satisfied. Why did you finally do the MRI? But if you rule that this is atypical normal tension glaucoma, like the cupping is there, but it is atypical. Okay, then you do a MRI, you will get up to 30% yield. Right? Remember this. Pallor is more than cupping. There's field defects are vertical or bitemporal defects, unilateral or asymmetric. Do MRI, very important. So these are some of the studies which were done, prospective and retrospective studies on patients with normal pressure but cupping. They saw the yield in to patients which were not actually compressive lesions or other cranial causes. The yield was as low as 0% for MRI. So remember, you cannot just shoot your patient to go for an MRI as soon as you see cupping and low pressures. Don't decide that it is a cranial cause of optic neuropathy. Don't immediately send. See at all the things. See the visual field, see the disc very carefully. So if we lower pressures, we see optic disc patient optic disc cupping, and we think it is glaucoma. We lower the pressure. What happens? Primary open angle glaucoma pressure is already high. Lower it. You have decided you will make the correct diagnosis that it is POAG. If it is NTG, lower the pressure. Response is very moderate. It is a very unforgiving disease. You do whatever you can, still it progresses because it's a vascular condition with a lot of predatory factors. But if you made a wrong diagnosis, it is vascular, or if it is other cause of non-glaucomatous cupping, it will progress. Nothing will happen. You just keep the patients on anti-glaucoma medication. Nothing is going to happen. Patient is not going to progress. You are happy. Patient is happy, but end of the day, you are wrong, and patient suffers from all the side effects of the medication. So if you see cupping, you should do all these things. One of these things will tell you that your patient is not having glaucoma. Do all these things. These are simple things. You start with ocular pressure. Low pressures, we are doing either with a normal tension glaucoma or with non-glaucomatous condition. See the pupil reaction. If it is RPD, unless and until you advance the total cut, not able to see at all, both are similar condition, then you are probably dealing with glaucoma. So examination, see all these things, they can all be clues. There's, if you see sector iris atrophy. It could have been previous, or if you see the anterior surface of the lens, there's pigment over there. There's some trauma sequelae. They can help you diagnose a past viral condition which led to a high intraocular pressure. See the angles. It is highly pigmented, but pressures are low now. Previously, because the viral attack, the pressures were high, but they were not controlled. They led to a cupping, one-time event. So you have to decide whether it is a progressive condition, whether it is a glaucoma or it a one-time event which has caused cupping. See the fundus, always see optic disc, the surrounding area around the optic disc, the macula, see the blood vessels. See the visual field, it is a vertical defect, it's a horizontal defect. If it is both above and below the horizontal raphe or it's just below the horizontal raphe, the upper part is not involved at all. Usually in glaucoma, both upper and lower part of the visual field will be affected. They are not going to vertical, they're going to be arcuate, but some part of them you get a nasal step, some part inferiorly or superiorly in both the hemispheres you will get. But in non-arthritic anti-ischemic optic neuropathy, it's going to be totally inferior or totally superior. Yeah. So now some cases optic. This is optic disc pit and a coloboma. So this is again I've taken from a paper. Very interesting. See, this is a pit, and this entire thing is the coloboma. You see, this is a slice of the retina, and you see this is the defect superiorly, but this slice is the disc of the retina. This doesn't happen in glaucoma. Be alerted. This is not glaucoma. As soon as you see this is not glaucoma, or else something else is also happening. And you see this pit, don't miss it. Don't think this is, oh, this is cupping. I'm done. If you see something here pigmented as a gold, this is a pit. This is a coloboma. This you see this is a telltale sign that you're not dealing with glaucoma, even though the defect looks like glaucoma. You see, this is the B scan, there's an excavation here. This is the SRF. You can see there's fluid here also. These are communicating, trying to communicate. You see there here that retina is not as healthy. There's some defects here in the retina. And see this line. Only coloboma causes this almost this vertical line here in the OCT. If you see this line almost vertical, think it is a coloboma. The normal disc will slide like this, like I showed you earlier. So another coloboma, this is my case, 45 years female. I was treating this patient as glaucoma. Other eye was not glaucomatous. Here you see this is the eye. This is the visual field defect. Okay, inferiorly, this is the GCC IPL. Possibly a horizontal raphe here. See the inferior RNFL defect. This is all corresponding to the inferior coloboma. Let's just see. See this very interesting slide. See, this is the retina you see here, some glial tissue over here. Here you see this vertical line. This slope is missing. This slope should be bilaterally. Because normally you get this type of slope. Then it rises here. This vertical line, if you get, this is where you know the retina is missing. This is the coloboma. Here this is the RNFL defect, and finally you do a 3D scan of the disc, and you see this defect. This is the coloboma. So this is a mass lesion involving the three gland, just compressing the nerve, and again you get a cupping, and so this is a mass lesion. This is a compressive lesion which can cause cupping. You see a cupping which is asymmetric, pale nerve. See this nerve is fine. There's no cupping here. So this is involving one nerve only. This is not affecting both nerves. So again, a pituitary tumor, and you see this beautiful vertically aligned vertical. This is the defect of the GCCIPL, vertical defects of the GCCIPL, vertical defects of the visual fields, bitemporal hemianopia. So this is arthritic ischemic optic neuropathy. This is non-arthritic. See, this is arthritic. Start with a very pale disc, very poor vision, and here you see this is almost no cupping here, no cupping. Here is cupping. So If you see the disc in other eye with almost no cupping, you are dealing with a non-arthritic condition. This was a patient. This is what happened. This was the attack when you will see the patient. There will be hemorrhages on the disc. There will be swelling on the disc, around the disc. And this is the other eye. Almost no cupping. Disc at risk. This is what happens. This is what the patient ends up with, cupping. This is a non-arthritic anti-ischemic optic neuropathy. And with the patient ending with cupping and intense inferior auditory scotomy. So just the last couple of slides, and so this is the NIMN is the commonest optic neuropathy after glaucoma affects T plus patients. And in the Olympic era, there's a lot of talk about this happening more and more. And initial estimates were this cupping was happening in 2 to 3% patient. Because why? Initially, the cupping is very less. So when the cupping increases, it still is very less. So you usually miss it as cupping. You see no cupping in one eye, you see about 0.2, 0.3 cup in the other eye. You think, no, this is not, and the pressures are normal. You're just going to dismiss the patient. But you have missed that optic disc pallor. You have missed that visual field defects. If you would have done, you would have seen the visual field defects. You would have seen the OCT on OCT. You will see the GCC IPL defects. You would have seen the RNFL defects. So initially it was just thought of as 2 to 3% cases, but now after all the OCT scans and advanced cupping, advanced screening of the patients, you see in up to 15 to 20 percent patients of non-arthritic and ischemic optic neuropathy end up with cupping. So yeah, that's the end of my talk, and thank you so much, JB, for hosting this talk, making it effortless for me, and thank you. So this is a shout out for Moxie Dexa, the brand of dexamethasone, moxifloxacin, and Vega Dexa. So thank you so much, JB.
Thank you, sir, for the wonderful presentation.
Yeah.
Thank you, Dr. Sagar, for giving your valuable time and throwing some lights, because as everybody knows, sir, glaucoma is not that much easy. Either it's a underdiagnosed or overdiagnosed. So you
Yes.
beautifully explained, sir, overall aspects of this various for the this optic disc and about the glaucoma. Uh,
Yes.
Manoj, we can, if there is any question, I think, sir, there are one question from the.
Yes, sir. There is a one question in the chat window. So
Sir,
you can
Dr.
stop your recording. वो sharing the screen, sir. So you
Okay.
can see the chat.
Okay. Let's stop sharing.
Yes, yes. You can see the chat. There is just one question from the audience.
Okay. Let me see. Yeah, the posterior bowing of the lamina cribrosa, it happens because of the chronic ischemia. There is apoptosis, and there is death of not only the retinal ganglion cells, but also the connective tissue. So there's in the posterior part of the lamina cribrosa, there's fibrosis also happening because of all this damage. So where sort of a scar tissue is forming. So it pulls the lamina. So lamina is not only lost its support at the back also, there's a loss of the tissue. And not only has it lost support, but because of the fibrosis are also happening there, it pulls the lamina backwards. So that is why there's a posterior bowing of lamina happening in non-arthritic and TS2 optic neuropathy.
So I
Thank you,
think
sir.
there is a no question. If anyone
If,
have question, please ask.
yes, yes, yes.
So
If anybody want,
no need to write in chat. Anybody can ask right off.
yes, yes.
And I would like to request to everyone, if possible, please switch on your camera so that we can take some screenshot for the webinar.
I finished almost in time. I thought I'll exceed the time, but it was close to 45 minutes.
Thank you very much. And thank you, sir.
Thank you. Thank you.
Thank you,
Sir,
everyone,
sir,
for
thank you, sir.
taking time out, and thank you, Dr. Sagar, for your precious insights about the optic disc and overall glaucoma management. And thank you all the doctors for your valuable time. So now you can log out, or if anybody is having any question, so now the floor is yours. I think, sir, there is no question. So thank you so much, everyone. And now we can.
Okay.
Thank you, Dr. Sagar, for the nice presentation.
Right. You are muted, Dr.
It
Trupti.
was a good presentation, Dr. Sagar. I enjoyed it. But what I feel like just wanted to add a few things like always your HVF will give you a clue. That is always vertical meridian. Whenever it comes, you should be on an alert. Like, yeah, this is neurological field. It looks, but then you need to correlate with the patients, their signs and symptoms, what you get, and with the associated histories. At times, luckily today, my PG also presented on the visual pathway, and we did had a discussion a lot about in relation with the anatomy, how is the horizontal raphe. Most of the finding goes with how is the insertions of the RFNL which has happened, how is the crowding occurred, and the way it gets presented on the disk. That today we were discussing. So everything got correlated for me today. Again, it was a revision. It was a good revision. Yeah, anti-G is always an entity where you missed many things. It does happen. But I feel like getting an MRI is better than keeping it
Not getting one.
underdiagnosed. Keeping it
Yes.
underdiagnosed, that's the thing. And asymmetric disc, nowadays a lot of things like it was good that you discussed about the pituitary, but then the pituitary that is prefixed, postfixed, those things, images were good, what you shared. So those were also, but pituitary often goes missed. The
Yes.
only thing is like if it is a meningioma, you lose your vision. That's the
Yes.
yeah, and
So the highlight actually, Dr. Trupti, I read a couple of papers, and there was a slide I moved through it very fast, and there are up to 5 studies, prospective, one prospective, a couple of them retrospective. They have seen patients with normal pressures, and they've seen with them with cupping, and they've done the MRI scan. The yield is as low as 0 to 1%. So unless and until you establish atypicality, like if it is looking like it's cupping in both eyes and you're getting a glaucomatous type of visual field defects, the NNR is not that pale, patient is an elderly gentleman, you can still skip that MRI. But if it's a young patient in 40s and you got cupping which is asymmetric, there's a lot of pallor of the disc and patient is not complaining of headache. पता नहीं पेशेंट को हेडेक तो होता ही नहीं है मतलब like whatever your typical things you're looking for, any signs of neurological deficiency, patients will definitely not have them. So
yeah,
yes, in those cases you see cupping, you see pallor, you see asymmetry, pressures are in the normal range. Yes, please go ahead. Patient is young. Again, but like compressive lesions, they happen at young patients and elderly patients. So bipolar sort of a presentation, so bimodal presentation. So at extremes of ages. So that there should be a caution there. If you see a young patient, relatively, let's say 20, 30s, and or very elderly patient, asymmetric cupping pressures normal, yes, you should be careful. But like you said, we always sort of miss that.
yeah. I think that nowadays, like with the OCT, many things are, and with the 3D imaging, a lot of things to be learned actually. If you
Yes.
spend on the OCT machine, there are many things to be learned.
This glaucoma patient of mine, I had been treating this patient with anti-glaucoma medication even, because this patient was being treated with anti-glaucoma medication when she came to me. So I continued with the anti-glaucoma medication, despite never thought of it, never gave it a second thought. Oh, bhai, itna sara disc cupping. So like okay, let's continue with anti-glaucoma medication. So at a much later date, I was listening to all these neuro lectures, in touch with all you guys, and thought, let's take a second look. Let's do an OCT scan. So there I had my diagnosis that this is the coloboma. I looked at the
Yeah,
3D picture. Yes,
very subtle things we catch on the OCT. Very subtle means
yes,
so many times I have seen like papilledema. Very subtle thing we have. It's not manifesting immediately, but the early thing. So inferior RFNL defect or superior RFNL thickening, which is there, itself gives you a clue that something is going to happen. And if you monitor it up, in such cases, do progress. The other thing, like we have to take care of the nutritional deficiencies. We have a lot of cases related to vitamin E and vitamin D. So, vitamin E and vitamin D are the major things which we are seeing, and therefore, inferior RFNL thickening is what we are seeing more in such
Thickening.
deficiency. Yeah, thickening is there. So we have to, check their B12 and D3 levels. So that's what we came across. Unfortunately, I don't have GC at my place. Like we don't have that installed, but still we try to study the pattern, how much is the loss there. This is what our own findings, what we have. Like Nagpur is a place where tobacco is more. So
Doctor,
NaOL and that's the major thing which is there.
and Dr.
Like,
Trupti is from AIMS Nagpur actually. She's a professor there. So yes, we are lucky to have her. She has done her fellowship from EV and she is a professor in
nothing
Europe.
like professor
We
or
are lucky to
anything.
have
I'm
her.
just
No,
yeah.
thank you so much for being here.
Yeah,
And
thank you.
yeah, so just one thing, madam, do you see cupping in these patients of nutritional optic neuropathies?
We don't see cupping, but what you see is like a temporal pallor in most of them. And sometimes the temporal pallor would be not there, but subtle, very mild changes you see. And on OCT, if you do, like you see those inferior RFNL thickening more. I just see, there is something which is so they say that it invades the myelin, actually, the deficiency, because of the deficiency. So it is called as a
The myelin is damaged.
myelin related optic neuropathy, it is called as. Like, so that's the only thing from my side. I think it was a really good lecture. You revised many things on Singh Hare and other things. I went back to my fellowship days.
Yes. I tried to correlate with the blood supply, the laminar process structure. That I tried
Yeah,
to do as much as possible.
even the laminar thing also, that is the place where, all the fibers, come, and then you get that which Madhu asked just now, Madhurika.
Yeah.
Nice. Thank you so much. Nice to be a part.
Thank you so much, madam. Thank you.
Thank you, Dr. Trupti, for such a wonderful your insights about all these things.
Yeah,
So,
welcome.
nice to have. And ma'am, your voice is so vibrant and dynamic. I am thinking it's early morning webinar is going on. It's not 8:30. Great to
Okay.
have you.
Yeah, sure. Thank you so much.
If anyone is having any other questions, otherwise we are good to log out. Dr. Sagar, I think there is no
Yes.
question.
Yes,
So
no current comments from anybody. Thank you all for attending this session. And if you have any question or any queries, you can bring to JB people and they can forward them to me. Or if you need any papers, any document, I can even get a PDF of this whole talk. If anybody needs any further inputs on this talk, I can share with them happily. Thank you so much.
sure.
I think we'll end this meeting.
Right, sir.
Thank
Thank you.
Good night.
Thank
Good
you,
night.
sir.
Thank you,
all.
everyone. Thank you,
Thanks,
everyone,
thanks
for
a
your
lot, sir.
time. Bye bye.
Bye.